welcome to all the new folks. Kyle Linton. Kyle Linton is joining us as part of the Where Are They Now series. I wanted to reach out to past presenters because I think there's more than just me who are curious about what are they doing? What do they do? How did they change? Are they still alive, right? What do they need now? How can we continue to help? So Kyle and several others have been very kind to come back and share the updates with us. Kyle presented probably 2 years ago. He was one of the early ones. Perseverance would be a word I would choose for Kyle. He has stuck with this and has had some amazing results, growing solidly along the way, had some opportunities that would have been great for any entrepreneur to say, yes, I've reached an exit point, but then made a very conscious decision to say it's not the right fit. I'm going to continue my pursuit and build it the way I envision it. So Kyle, with that, I welcome you back, and we look forward to hearing the update.
Awesome. Well, I think I'm just going to shout and put the mic down. So can everybody hear me okay?
Yeah.
Okay. Let me know if you can't, and I'll just keep shouting. But my name is Kyle Linton, and a few years ago when I was at NC State University, we launched a company originally called Track to Quit, but Nicotrax is our new name. And the original premise is, what if we could create a better way to track and understand why people are doing what they're doing and help treat them? So the first disease and condition that we took on was smoking cessation. So the premise was, how can we better understand why someone is smoking, what their triggers are, and then deliver a more customized and effective program to help them quit? So the first step of what we did is we went out in the marketplace and we said, okay, what's out there and what works for people? And in a lot of that market research, what we found was that the average solution to help somebody quit is only about 10 to 15% effective. So as you all know, there's all kinds of products out there that are drugs. So you have patches, gums, lozenges, Chantix, Zyban, and other prescriptions that are meant to help people from a chemical standpoint. And then you have programs like quit lines, text-to-quit programs, and behavioral support that helps understand circumstances where people are and more effectively give them customized treatment. The problem with these things is that individually they're only 10 to 15% effective, and when you combine them, they're only 20 to 30% effective. On top of that, they're highly localized, so you have to go into a clinic to see a doctor 2 or 3 times. You have to get on a phone and talk to a counselor in order to effectively receive this treatment and be successful. So we've seen quite a few scalable mobile apps come out that start to do some of these things. But we said, what if we could do it better? What if we could better collect information, better customize programs to users, and better treat programs to get better results? So our vision with Nicotrax overall is to develop the most customized, scalable, and effective digital therapeutics for employers, health plans, and users. In healthcare, there's so many different constituents that take part in a user's healthcare cycle that it's important to keep all of these players in mind when it comes to providing financial incentive to treat patients and seeing efficacy results from it. So looking at smoking specifically, in the United States, there are approximately 40 million smokers. And on average, smokers cost the employers and the payers hundreds of dollars per year, which averages out to about $560 per smoker. And on top of that, the average smoker will relapse 8 times before they are successful, which goes to show that current solutions just aren't working. So what we have developed is a quitting smoking program that incorporates the power of a customized quitting plan, a virtual counselor, social support and content, and nicotine replacement therapies. So how our system works is a user up front applies to our program, enters in demographic information on their motivation, information on their level of consumption, and other information that's going to allow us to customize the program to them. They then begin the program and will receive their nicotine replacement therapies. And with these therapies, they will track their consumption over time of cigarettes and cravings, as well as monitoring their compliance of nicotine replacement therapies. So we're able to see a picture of the nicotine that the user is consuming and apply specific counselor or social support group. So we tried to make it as simple as possible for users and as simple and customized as possible for users so that they can do it from the comfort of their own home. So they start by filling out this application, and then we accept or reject them from the program, and they're able to complete the 10-week program all from wherever they're most comfortable. So for us as a company, why we're different than all of our competitors is that we provide access to never before collected user smoking and consumption data. So if we're able to understand and contextualize the patterns that people have around smoking, and to give you one anecdotal story, we have there was one smoker that we had that ran through our program that we noticed a spike in her consumption. And it was a really weird period of time. It wasn't a weekend. It wasn't kind of an obvious sign of drinking. And so we said, what's going on? And she said, March Madness. And so we thought that was a great example of understanding how for each specific user, everyone has different consumption patterns and triggers. For another set of users, we had 2 delivery drivers that we would notice via the GPS that they would only smoke when they were driving between deliveries, due to high stress, due to a work environment. And so then we were able to take some of the body of literature and content that was out there and apply it very specifically to those users. So overall, this provides us the ability to turn user data into behavioral profiles and then take that and see use trends to identify habits and push smarter content and smarter drugs. So our 10-week programs are data-driven, they're tailored, and they're accessible to each user from the comfort of their own environment. On top of that, we can work with pharmaceutical companies to suggest nicotine effective for each individual user. To give you an example of that, some users have a high level of consumption, so they're smoking a pack a day. So we'd want to try to provide that user with a patch as opposed to a piece of gum, whereas a user that might smoke 3 to 10 cigarettes a day, we'd want to give them a piece of gum to replace each of those individual cigarettes. So far we've run a couple pilots and studies. We ran a UNC IRB approved grant-funded pilot trial. And then we ran a partnership pilot with Micromass here in this region, which is a behavioral communications organization. So both of these were preliminary proof of concept trials, but they showed a reduction of 50% in users' consumption and a post-trial quit rate of about 30%. We utilized Micromass behavioral counselors in that trial, which also gave us more knowledge and insight as to the user experience for the counselors and how they could better support smokers. In addition to that, we've run a bunch of focus groups, formal UX analysis with surveys, and have just spent the past several years just talking to smokers and understanding how we can develop a more simple and effective system. So over the past few years, we've focused on several development partners. We're currently talking to the ASSIST program to try to find better ways to build in sensor technology and understand, basically create more data inputs that are automated as opposed to manual entry. We're talking about doing some pilot research with the U.S. Army, and then we've also worked with researchers at UNC, Duke, and NC State. But one of these highlighted partnerships we wanted to make was Medical University of South Carolina. So we have a professor there that we're working with that's received over $1 million in NIH funding to test and validate some of the intricacies of the data collection and how it affects treatment. So understanding the patterns between GPS and ecological momentary assessments, fancy research term for understanding individual use behaviors at a specific period of time. And we also want to do more research into the hotspot profiles and maps, so we're able to start to see these are the patterns that a user has over time. Here's how we can layer information on top of that with bars, restaurants, other social environments, so that we can better enact treatment for those users. And then over time, all of this data that's feeding into our system, we can then apply in an artificial intelligence standpoint to offload, offload the work from the counselors. So we're able to automate more messaging that has a higher level of customization to smokers in a more effective manner. So a little bit about our advisors. Patricia Kovacevic was on the senior general counsel of Nicotrax Labs. One of our investors, Alex Osinski, is an ex-VC Silicon Valley technology expert. And then we work very closely with Drew as a mentor in the healthcare space and Jason in the product development space. So we got this nice, strong product testimonial from Jed Rose not too long ago. And he was the co-inventor of the nicotine patch. And it kind of speaks to the viability of a solution like this. So overall, taking all this into consideration, where we are going with this, and coming back to 1 million cups and expressing kind of the direction that we want to take. And for us, we see massive partnership opportunities. Chrono Therapeutics is a company in the Valley that's raised over $100 million, and Chrono is creating a smart transdermal nicotine and opioid delivery device. So in theory, they can provide custom levels of nicotine and opioids throughout the day, depending on user profiles and treatment programs. So one of the discussions we're having with them is how can we apply our technology to what they're doing to help better contextualize drug delivery and ultimately drive the efficacy rate up of these sort of products. The holy grail in our mind is understanding user behaviors and delivering drugs and behavioral support completely virtually and completely customized. Providing more information. In addition to that, we are seeking commercialization opportunities with MetLife currently to figure out how this can play into life insurance and creating a more adaptive underwriting model. And we're also talking to the Foundation for a Smoke-Free World about non-dilutive grant funding and continuing to refine the system and adapt it over time. Overall for us, taking a step back into where we started with this presentation, combining pharmacotherapy, behavioral support, and scalable health products, we think that there's a massive opportunity to take this sort of product outside of just smoking cessation and into opioids, into substance abuse. And we're currently talking to partners to do just that. Basically, understanding at a fundamental level why people are doing what they're doing and being able to treat them more effectively through customized drugs and behavioral support, treat millions around the globe in the next 100 years. So what I would ask from this community is we're really interested in talking to additional commercial partners. This could be anyone from an employer who wants to implement our system, an insurance company who we want to partner with to drive return on investment, or strategic partners like a Micromass or other organizations that focus in this space. And in addition to that, one of the conversations we're having right now is raising an additional stage of funding to catalyze progress and continue product innovation and just continue trials based on the proof of concept data that we have so far. So thank you guys for taking the time to listen to our presentation. If you want to reach me, my email is kyle@nicotrax.com, and I'd love to talk to you afterwards.
All right, we're open for questions.
Kyle, what is the cost model with an individual through the
Do
program?
me a favor and stand so we can all.
Sorry.
So
What is the cost model to put someone through the program?
it's a little bit of a difficult question, but right now what we are looking at is $150 plus nicotine replacement therapies. The things that edit that revenue model would be, when we talk to employers, they all work with different insurance companies, and all the insurance companies provide different reimbursements for the nicotine replacement therapies. So that's one piece to keep in mind. In addition, it depends on how intensive, whether or not we choose a more automated source of counseling, or whether we do or whether we utilize certified tobacco treatment specialists, which from a service standpoint just costs more money and more money per head for the program.
Just kind of building on that, so the 150 a person, that's your internal cost to process and help somebody on an annual basis? Is that?
No, that's the cost that includes overhead and profit for us. Internally, like I mentioned a second ago, the costs for us are dependent on the drugs and on the level of behavioral support that we provide to users, which oftentimes comes through a relationship with the insurance companies. Because the insurance companies have a lot of certified tobacco treatment specialists, counselors, that they have access to. So each individual company that we're talking to, we are attempting to leverage those resources which are already established, but internally we have our own certified tobacco treatment specialists that we can work with, but that increases the cost per head to us, thus potentially increasing the cost of the program.
Right, okay, so flip it around. If you're dealing with cost and helping make something more efficient and effective, right, at the end of the day? So if you can now illustrate that your application can save them $20, $30 a head on their side, you can now set it up. The way this is hitting me is you're a white label app that just goes in and helps out all these different people that are helping out. You automatically get a scale, so you sell to these organizations the white label, and you have a monthly fee per head, and you'll be able to generate probably pretty significant revenue on those contracts, is my guess.
Yeah, so a couple interesting things with revenue, with the revenue model. There are a lot of companies in the Valley that have shifted from something like what we're doing until they get more clinical data, and then they shift to more of a basically an effectiveness revenue model, where if they are proving, like there's a company called Amada Health that has made that shift over time, and they're in pre-diabetes and absolutely killing it right now, but they've basically proven to the insurance companies that if you give us, the insurance companies and the employers, if you give us X dollars, we're going to be able to treat X number or Y number of people, and the output is going to be this in terms of return on investment. We don't want to break this up into a subscription model, because the 10-week program and the way that we have designed the product it's critical that we try to put people through that, because this is a continual cycle, but the more intensive support you can give people through a guided program, the more effective or the greater chance that they'll have to succeed. That being said, there are clever things that you can do that if people drop out of the program, you can cycle them back in and utilize the subscription model kind of in that effect. But overall, we want to wrap this around a defined 10-week program that we are charging to the employer and shifting over time into that efficacy-driven revenue model. Does that make sense?
Yeah, Kyle, thanks for coming back and sharing your story. Sounds
Absolutely.
exciting. I appreciate the passion that you shared. My question goes back to a phrase that you use that I don't think I've heard before, automated counseling. Can you talk a little bit about how that happens and the data that you base that on?
Yeah, absolutely. So there's the patient-centered approach to looking at this, and then there is the kind of internal way that we approach things. The patient-centered approach is having a human touch and a human presence is almost always going to be more effective. Having someone that can understand your behaviors and listen to you and empathize with you and provide you with customization, from a user standpoint, not always, but the majority of the time is more effective. From our standpoint, some of the metrics, so we'll collect metrics on locations when people are smoking, time they're smoking, the cravings that they have, and the nicotine replacement therapies that they're using. Contextualize that, put that on a map for counselors, while also providing them with demographic and employment information so that we can create this broad picture. And then we have certain features in our software that allow us to automate messaging and to attach motivational content ahead of time, or just automatically create messaging libraries that automatically respond to certain trigger events. So we see a blend in utilizing a service like that, which offloads the work from the counselors, while also providing the counselors an opportunity to have a template to create highly customized messages that are sent to each individual user that says, hey Mary, I noticed that your consumption spiked and that we do this morning, which is what happened to our user before. That sort of messaging our system is going to have a more difficult time figuring out, but a counselor can intervene and help provide that support. Thank you. Sure.
For this
Sit back down.
see this body.
That's great.
For this funding round that you're going to engage in, I know I can't ask how much, so I'm not doing that. But what are you going to use the money for, and what business milestone would you achieve with it?
Absolutely, that's a great question. So the big things on our radar right now are a potential partnership with this organization in the Valley that's created the smart drug delivery device, which would be a full contract development, which would provide us with revenue. But separately of that, we're very interested in running larger scale pilots. And one of those discussions we're having is with MetLife and with a division in MetLife in Asia. Because the opportunity globally for us, if smoking rates stay the same, 1 billion people will die by 2100. 1 billion. And so the funding that we are obtaining not only goes into continued product development, but it goes into intellectual property to protect the system that we are creating of data collection and of behavioral profile identification and of content and drug delivery. So it'll go into intellectual property for that, but it's also going into large-scale efficacy trials with other partners. And we're seeking NIH non-dilutive funding to do the same sort of thing. But from a move quickly commercial perspective, we are able to take that seed round of capital and put it into a large commercial relationship with an employer and walk out of that with a strong indication of efficacy. We should be able to sell this like hotcakes, especially compared to the other products in the market that suck, honestly.
So this money takes you to a point where you can launch this business in a real way.
In a scalable fashion. We've been grinding for years, and we're now, healthcare is such a game of relationships. And let me give you one example. One company we were talking to, I originally met their head of product at a conference 2 years ago, and then that person left the company and introduced us to the founder. And then the founder left and introduced us to one of the vice presidents. And then the senior vice president left and introduced us to the CFO. And that's where we are now. And so convincing a partner in the relationship of trust and breaking in the door in healthcare, especially with these large insurance companies, which move very slowly, takes time. But once you're in the door and once you can prove efficacy and the cost return, or the return on investment of that efficacy, you can scale very quickly. In healthcare, a term that we've heard is first to second, and it's so true. And we are just breaking in and ready to go to second.
In the back.
Does the counseling have to be face-to-face, or can you use some kind of webinar concept to communicate with people?
Yeah, so the counseling all comes through our mobile application and through the dashboard. So counselors access our dashboard, they see data over time, they push content to users, which the users will receive in an app, and the counselors can push from a dashboard. There are some specific use cases with mental health and a few other areas that we're considering a localized counseling presence as well. to add a little bit of additional intensity, for every different treatment. There's a massive problem with smoking in mental health because mental health physicians used to treat, or not treat, but provide incentive to mental health patients in cigarettes. They would provide them with cigarettes. And there is some actual preliminary data that says that nicotine is effective in for some mental health conditions in terms of treatment, but combustible cancerous cigarettes are not helpful in that regard. Meeting people where they are and creating specific treatment paths for different subsets of users is important. Thus, localized counseling, is one of the tools that we are considering putting in this toolbox for the right subset of patients.
One quick question. You mentioned the Valley a couple times. Are you considering a national rollout or other areas of the country, or what's your goal?
Yeah, so for us, healthcare is so localized currently. But, the current model of healthcare, people talk about healthcare being broken, and healthcare is not broken. We've just become we'll get there in a second, but healthcare in the United States has become so good at treating people when they are sick, but it is not good at treating people before they are sick and preventing them from getting sick. So for us, part of that conversation comes with large health organizations. Do we go and work with providers to prescribe this technology, similar to a company that's coming out of the Valley called Pear Therapeutics, where they're working very closely with the FDA and providers to basically create prescribed digital therapeutics as opposed to easily accessible digital therapeutics. So for us, I think our primary target is to focus on localization of our technology in specific regions. So certain healthcare organizations own certain regions. We talked to Anthem a little bit. We've talked to MetLife. But for each of these different stakeholders, for life insurance, there's a different distribution path than there is for a health insurance company like Anthem. So it's tricky in that we would like to roll this out nationally, but it has to go through these larger distribution partners that have concentrated healthcare resources in specific areas. Thus, we start with pilots in those specific areas and roll out to all their other markets after establishing a relationship and establishing advocacy.
I'm in healthcare, and one of the things that you probably should address is, you're right, North Carolina probably can start very localized. We're going to move away from a fee-for-service model to an MCO model, and MCO is all about preventive care, and this is preventive care. You probably should talk to 7 or 8 MCOs who will be left here in the next 2-3 years when Medicaid reform is completed, but they might be very interested in what you're doing on the preventive side of healthcare problems.
We'd love to talk to them, and if you happen to know any individuals that are worth having coffee with, I'd love to meet with them. And the other thing that I will mention from a humility standpoint is healthcare is very complicated, and we're very young, and we started this right out of university, and we've learned a lot. But there are a lot of things we don't know, and the more conversations that we can have to understand, because the value chain for this is very complicated. Smoking is one of the largest costs to our healthcare system, but it's seen in employers, it's seen in payers, and it's seen for individual users. But being able to tie that to very specific metrics within each of these larger organizations and stakeholders is very difficult. Because for life insurance, the metrics are going to be very different than they're going to be for a health insurance company. Health insurance companies are going to try and keep people from getting COPD and lung cancer and these other conditions that are expensive, whereas life insurance is trying to keep them alive so they don't have to pay for premature death associated with smoking, which if you smoke, you have a 50% chance of reducing your life at some level. So understanding the value chain and being able to get within these organizations and tie it to specific metrics allows us to improve that revenue model over time and keep it more closely related to advocacy. But we love to talk.
Probably last question, Chris.
Have you considered, I understand trying to partner with the health organizations and these kind of places that get rolled out, but have you looked into partnering with analytics agencies that already have long-standing contracts with the agencies you're trying to work with? So I know of some organizations, some companies that have had like a partnership with SAS because they already have it in with this kind of thing, and they're not offering the same kind of user experience other pieces that you have going for you. So you can use it to kind of leverage and come in the back way, and they have like
We have not pursued that. That's interesting. I'd be curious to look into that, and talk to you more about that. I think for us it comes down to how these organizations, how the analytics organizations work with the large employers, payers, whoever, and if the same channels that they are utilizing to do the work that they're doing can be utilized for like a wellness benefits play. Whether, I mean, it basically is just an org structure question. But I'd love to talk to you more about it. That seems like an interesting approach. Awesome.
All right, Kyle, thank you very much.
Thank you guys. Appreciate it.